Welcome to the deep dive. We're jumping straight into a topic that, well, it might be on your radar, especially if you're doing some revision.
Absolutely.
We've got hold of some MSRA revision notes here, specifically focusing on the skin condition vitiligo.
That's right.
And our plan today, our mission, if you like, is to pull out the really high-yield stuff from these notes. Structure it so it's actually useful for revision, helps you understand and remember the key bits.
Exactly. We want to make this efficient for learning. We'll cover the essentials, definition right through to complications, using these notes as our guide.
Perfect. So think of this as us filtering the core knowledge for you. Let's
Correct.
dive in then. To start us off, what's the basic definition? According to these notes, what is vitiligo?
Okay, definition. So vitiligo is described as a chronic skin disorder. The key characteristic is the loss of melanocytes.
Right, the pigment-producing cells, the ones giving skin its color.
Precisely. And the result of losing them is depigmentation. You get those well-known white patches. The notes really stress that it's considered an autoimmune condition.
Ah, okay, that autoimmune point feels important. I suspect we'll circle back to that quite a bit.
It really does tie a lot together, yeah. A couple of key stats from the notes. It affects around 1% of people, so it's not exactly rare.
1%.
And it often starts to develop by age 20 or 30, although it can actually begin at any point.
Okay, so chronic, autoimmune, loss of pigment cells, white patches, about 1%, often younger adults, but not always. Got it. Now, the notes mention different types, don't they? How is it classified? What are the main categories we need to know?
Yeah, they break it down. The most common type is called non-segmental vitiligo, or NSV. The really key feature here is symmetry. The white patches usually appear symmetrically, often, on both sides of the body.
So like if there's a patch on one knee, you'd probably find one on the other knee too.
Exactly. That kind of mirror image pattern is quite typical for NSV. The notes do list subtypes: focal, mucosal, acrofacial, which is hands, feet, face, generalized, universal. But the main takeaway for NSV is that widespread, often symmetrical pattern.
Okay, symmetrical is NSV. What's the other main one?
That's segmental vitiligo, or SV. This one's less common. It tends to come on quite rapidly, and the big difference is it's unilateral, just one side.
Okay.
It often follows what we call dermatomes, the area of skin linked to a single nerve, and it quite often affects the hair in that specific segment, turning it white.
Right, so NSV, think symmetrical, maybe more linked to general immune stuff. SV unilateral, faster onset, follows nerve lines, often hits the hair too. That feels like a really crucial distinction for thinking about diagnosis and maybe even causes.
It absolutely is. It's a key difference. The notes also briefly mention a mixed type, which is apparently rare, and an unclassified type, which is sort of a placeholder while they observe the pattern.
Right. Okay, let's get to the big question then. The causes. Etiology. The notes seem pretty upfront that it's not fully understood.
That's true. It's presented as multifactorial, so likely a mix of things contributing, but the notes definitely lean heavily on the autoimmune theory as the main explanation. The idea is the body's own immune system makes a mistake and attacks and destroys its melanocytes.
So the pigment cells themselves become the target of the immune system. Wow.
Yeah. They do mention other theories too, like neurochemical factors, maybe nerve endings releasing harmful substances. There's autocytotoxic theory, where melanocytes might sort of self-destruct. Biochemical issues are mentioned, and definitely genetic predisposition. Some people are just more likely to get it genetically.
But lots of potential factors, but autoimmune is the front runner.
It seems to be the consensus, yes. That autoimmune destruction of melanocytes, specifically from the epidermis, is seen as the core mechanism.
Okay. And given that strong autoimmune connection, does this mean people with vitiligo often have other related health problems?
Yes, absolutely. This is flagged as a really important association in the notes. There's a higher rate of other autoimmune diseases in people with vitiligo. The list specifically includes type 1 diabetes, Addison's disease, autoimmune thyroid disorders like Hashimoto's or Graves', pernicious anemia, which is a B12 issue, and alopecia areata, that's the patchy autoimmune hair loss.
That's a key list for revision, definitely. So if you're thinking about vitiligo, you absolutely have to consider screening for these other conditions.
Couldn't agree more. Now, thinking about risk, who's more likely to get it? What risk factors do the notes highlight? Well, the big ones are having a family history of vitiligo itself, or having one of those other autoimmune diseases we just listed. Certain genetic factors are also involved.
And does it affect certain groups more than others, like race or gender?
The notes are quite clear on this. It affects all ages, all races, and both sexes equally. However, the depigmentation can be much more noticeable visually in people with darker skin tones.
Ah, right. The contrast makes it more obvious, so maybe diagnosed more readily.
Potentially, yes. It might lead to seeking help earlier.
Any other maybe less common risk factors mentioned?
Yes, interestingly, the notes also list a history of melanoma and cutaneous T-cell lymphoma as additional risk factors.
Okay, that's definitely one to file away, not the most obvious link.
Yeah.
What about things that might actually trigger it, set it off, or make it worse?
Yeah, triggers are mentioned. Things like significant emotional stress, childbirth is listed, and physical trauma or injury to the skin. This trauma link is quite important. We'll come back to it.
Okay.
Also, exposure to certain chemicals, specifically mentioning phenolic or catecholic derivatives, these can be found in some industrial settings or even some disinfectants.
So stress, big life events, skin injuries, even chemicals could potentially start it or flare it up.
Yeah.
Right, let's dig a bit deeper into the pathophysiology. You said melanocyte destruction, but what's the actual process thought to be?
So the core pathophysiology, as the notes laid out, is definitely that destruction of the melanocytes. And while we said the exact why isn't fully pinned down, the mechanism strongly points to autoimmune-mediated cytotoxicity.
Meaning immune cells are actively attacking and killing those pigment cells.
That's the leading theory, yes. And genetic factors are thought to play a role in how susceptible someone's melanocytes are to this kind of attack, or maybe other destructive processes. So you could say genetics kind of loads the gun.
And then a trigger, or maybe just the immune system going awry pulls the trigger.
Something like that, yeah. Leading to the loss of these cells from the top layer of the skin, the epidermis.
Okay, that makes sense. Definition, types, causes, mechanism. Check. But, white patches on the skin aren't only a vitiligo. What else could it be? What's on that differential diagnosis list from the notes?
Yes, the differentials list. It's quite long, but really important for revision. So conditions that might look similar include tinea versicolor.
That's fungal, right?
Yes, a common fungal infection. Then there's piebaldism, which is actually congenital, present from birth. Idiopathic guttate hypomelanosis. Those are the small, sort of confetti-like white spots you often see on shins or forearms, especially with sun exposure. You can also get hypopigmentation from things like using potent topical steroids for too long, or just from scarring. Then there's tuberous sclerosis, post-inflammatory hypopigmentation, which is color loss, after something like eczema or acne has healed.
Right, the skin remembering an injury.
Exactly. Also, pityriasis alba, often seen in kids, mild scaly patches on the face. Leprosy, specifically the tuberculoid type, can cause numb white patches. Halo nevus, that's a mole with a white ring around it. Lichen sclerosis atrophicus, this one's often itchy, typically affects the genital area.
Itchy, okay, that's a clue.
Melasma, although that's usually darker patches, sometimes it can present unusually. Albinism, which is a genetic lack of pigment everywhere. And morphea, which involves thickened skin that can sometimes lose pigment.
Wow, okay, that is quite a list. For revision, it feels like knowing the list is step one, but maybe having a quick distinguishing feature for a few key ones is helpful. Like tinea versicolor fluoresces under wood's lamp, doesn't it?
It does, yeah. And things like lichen sclerosis being itchy, or morphea having thickened skin, or just the patient's history pointing to post-inflammatory changes, those kinds of clues help narrow it down in practice, even though the notes just give the names.
Makes sense. Shifting focus a bit, how common is this? Epidemiology. What do the notes say for the UK?
The UK prevalence mentioned is between 0.5% and 2%, affects all ethnicities, all races, again, just more noticeable in darker skin. Interestingly, it says it's diagnosed more often in women, but the actual distribution between sexes is thought to be equal.
So maybe women seek help more often, or it's noticed more.
That could be it. Onset is frequently before age 20, but really it can affect any age group.
Okay, fairly common, that affects everyone. Let's picture it now, the clinical presentation. What does vitiligo actually look and feel like?
Well, the classic sign is those white depigmented patches. They can be small and localized or cover large areas of the body, and as we keep saying, much more visually striking in darker skin.
Where do you typically see these patches?
Common spots listed are the face, hands, feet, and the genital areas. Patches are usually well-defined, sharp borders. And remember, for NSV, that symmetry is key.
Does it only ever affect the skin itself?
No, it can also affect pigment in the hair. So you might see white patches of hair on the scalp, or white eyebrows or eyelashes. That's called poliosis. The notes also mention a possible, though less common, impact on the retina in the eye.
Any variations in how the patches appear? Different looks?
Yes, the notes mention a few variants. There's trichrome vitiligo, where you see three colors. Normal skin, light brown, and then the white patch. Inflammatory vitiligo has raised, reddish borders around the patches, and there's something called blue vitiligo, which is rare.
And you mentioned trauma earlier as a trigger. How does that show up clinically?
Ah, yes, this is really important. It's called the Koebner phenomenon. The notes explicitly state that skin trauma, a cut, a graze, friction, even sunburn, can trigger new vitiligo lesions to appear in that specific area of injury, even if it wasn't affected before.
Right. The Koebner phenomenon, that's the term.
Yeah.
So rubbing from clothes or a scrape could actually cause a new patch.
Potentially, yes. Symptom-wise, it can start any age, often young. Sometimes people report itching right when the patches first appear, but usually the patches themselves don't have any physical symptoms. They don't hurt or itch later on.
But the impact isn't just physical, is it?
No, absolutely not. The notes really hammer this home, the potential psychosocial impact. Because it's visible, it can cause significant distress, anxiety, self-consciousness, really affecting quality of life.
And don't forget the link to those other autoimmune diseases we listed earlier. Any practical day-to-day advice linked to the appearance?
Yes, a really crucial one. Because the white patches have lost their melanin, they've lost their natural sun protection, so they don't tan at all, and they burn very, very easily. Sun protection is absolutely vital.
Makes total sense. Okay, so how is it actually diagnosed? What investigations are typically done?
The diagnosis is primarily clinical. It's usually based on recognizing those characteristic white patches during a good look at the skin.
So just looking is often enough.
Often, yes, combined with taking a detailed medical history. Looking at all skin surfaces helps determine the pattern and extent. The notes also mention using a Woods lamp.
What's the benefit of the Woods lamp again?
It uses UV light. It can help highlight patches that might be subtle in normal light, make them stand out more. And crucially, it helps rule out things like Tinea versicolor, which glows, it fluoresces under the Woods lamp because it's fungal. Vitiligo doesn't fluoresce.
Okay, clinical look, history, maybe Woods lamp. And because of those associations.
Yes, absolutely essential. Assess for signs of those linked autoimmune conditions, diabetes, pernicious anemia, thyroid issues, Addison's. The notes suggest thinking about blood tests, like thyroid function tests, and checking for certain autoantibodies.
And importantly, the notes also say to evaluate the impact on the person's quality of life.
Yes, it's listed right there as part of the assessment. Recognizing the human side of it is just as important as identifying the skin changes.
Right. Okay, let's talk treatment, management. What can actually be done? The notes seem to suggest quite a few options.
They do. And the key message is that it's tailored. Treatment depends on the individual, how much skin is affected, where it is, and crucially, how much it's bothering them. It's definitely not one size fits all.
What are the sort of baseline things everyone should do? General measures.
General measures come first and are vital. Rigorous sun protection is #1 clothes, high-factor broad-spectrum sunscreen, avoiding sunbeds. This prevents sunburn in the white patches and also minimizes tanning of the surrounding skin, which reduces the contrast.
Makes sense.
Also, trying to minimize skin injury helps prevent that Koebner phenomenon, avoid unnecessary trauma.
Right. Avoid triggering new patches if possible.
Exactly. And ongoing monitoring for those associated autoimmune diseases, plus regularly assessing the quality of life impact are also standard parts of management.
Okay, that's the foundation. What about covering it up? Camouflage.
Camouflage options are important. The notes mention highly pigmented cover creams or powders. These can be matched to the person's skin tone. They're often waterproof and designed to last. Self-tanning products are another route for adding some temporary color.
Any more permanent cosmetic options?
Yes, cosmetic micropigmentation, basically tattooing, is listed. But the notes add a word of caution that the results can be unpredictable.
Okay, so cosmetic fixes. What about medical treatments trying to actually bring the pigment back or stop it spreading?
For limited areas, especially non-segmental vitiligo, topical treatments are often the first step. Topical corticosteroids are one option. They work by reducing inflammation and modulating the immune system, trying to calm down that attack on the melanocytes.
Which ones?
Potent ones like mometasone or betamethasone, valorate 0.1% daily, are mentioned. But there's a caution about using potent steroids on the face or during pregnancy because it's potential side effects like skin thinning.
Right, so maybe okay for patches on the body, but what about the face or sensitive areas?
That's often where topical calcineurin inhibitors come in. Examples in the notes are tacrolimus and pimecrolimus creams. They also calm the immune response, but generally have a better safety profile than strong steroids, especially for the face and longer-term use. An initial 6-month trial is suggested for these.
Okay, so topicals for limited areas, steroids for body, maybe calcineurin inhibitors for the face. What if it's much more widespread?
For more widespread vitiligo, or even localized patches that are really impacting quality of life, phototherapy becomes a major option. This uses specific wavelengths of ultraviolet light.
How does light help?
It's thought to stimulate the remaining melanocytes to produce pigment and spread, and also to modulate the local immune response in the skin. Narrowband UVB, or NB-UVB, is highlighted as being particularly effective, especially for widespread NSV.
Any other light therapies?
PUVA is also mentioned that combines a medication called psoralen, taken by mouth or applied topically, with UVA light exposure. It's also effective, noted particularly for the face and trunk. For very large affected areas, say over 15–20% of the body, whole body phototherapy treatment might be used.
So topicals for smaller areas, light therapy for bigger areas or significant impact. Are there surgical approaches?
Yes, surgical options exist, but they're generally reserved for stable vitiligo, meaning no new patches or spreading for at least a year. The idea is to transfer pigment cells, or skin containing them, to the white areas.
How do they do that?
Techniques listed include non-cultured melanocyte keratinocyte cell transplantation, taking tiny punch grafts from pigmented skin, using suction blister grafts, or split skin grafts.
Sounds quite involved. Definitely only for stable disease. What about the reverse? Instead of trying to repigment, making the normal skin match the white patches?
That's called depigmentation therapy. It's mainly considered for people with darker skin tones who have very, very extensive vitiligo, where repigmenting everything just isn't practical or maybe isn't wanted.
So you bleach the remaining normal skin.
Essentially, yes. You apply a specific cream to the normally pigmented skin to permanently destroy the remaining melanocytes, aiming for an even, white skin tone overall.
Permanently. That sounds like a huge decision. Is a specific cream mentioned?
Yes, the notes give monobenzone ethyl ester cream as the example, and they explicitly state the depigmentation it causes is permanent.
Okay, so lots of options. What's the typical pathway? What can be handled in primary care before needing a specialist?
Primary care plays a big role in initiating those general measures, sun protection advice, discussing camouflage. They can sometimes prescribe camouflage creams directly or refer to a specialist camouflage service. Patient support groups like the Vitiligo Society are also important resources they can point people towards.
And when should they refer onwards to dermatology?
The notes give pretty clear indications. If the vitiligo is spreading rapidly, if the diagnosis isn't certain, if it's segmental vitiligo because the management and prognosis can differ, if the face is involved due to the impact and different treatment needs during pregnancy, if there's significant psychological distress, if large areas are affected, likely needing phototherapy, or simply if primary care treatments haven't worked.
That's a really useful list for knowing when to escalate. Okay, nearly there. What about the long-term outlook? Prognosis.
The notes describe the course as, well, unpredictable.
Unpredictable how?
Some people might actually see some spontaneous repigmentation color coming back on its own without treatment. For others, the vitiligo might progress and spread over time. And the response to any of the treatments we've talked about can vary a lot between individuals.
So no guarantees either way, really.
Pretty much. And the notes circle back again to that key point. While the vitiligo itself usually causes no direct physical harm, the potential for significant psychological and emotional impact is always there.
That psychosocial aspect keeps coming up. It's clearly vital. Are there any direct physical complications listed?
Yes, a few. The main complication highlighted, yet again, is that psychological and emotional distress from the appearance changes.
We certainly got that message loud and clear from the notes.
Definitely. Beyond that, the physical issues relate directly to the lack of melanin. As we've said, that depigmented skin is much more prone to sunburn.
Right.
And because of that increased cumulative sun damage over the years, the notes mention that people with vitiligo are more prone to developing sunspots and significantly have an increased risk of skin cancer developing specifically in the depigmented areas.
So the vitiligo isn't cancer, but the lack of protection makes those areas vulnerable.
Precisely. Which underlines why regular skin self-checks and really strict sun protection are so important as ongoing preventative measures.
This deep dive has really pulled the threads together from these notes. It's so clear how understanding that core autoimmune destruction of melanocytes links the cause, the associated conditions, and even guides the treatment approaches.
Absolutely. Understanding that mechanism helps make sense of the rest. And that consistent emphasis on the psychosocial impact, even though the condition itself might be seen as just cosmetic physically? That's a huge takeaway.
It really is. For anyone listening and using these notes for revision, hopefully seeing how these pieces fit together, definition, cause, types, differentials, management, prognosis, and remembering those key points like NSV versus SV, the autoimmune links, Koebner, referral criteria,
Yeah.
that's the goal.
Yeah, structuring your revision around those key concepts and links from the notes should really help it sink in.
Before we finish up reflecting on all this,
Yeah.
is there one final thought or question that emerges from this material?
Well, given that vitiligo itself is physically benign but can cause such profound psychological distress, it does raise an interesting point, doesn't it? How do we, in medicine, best balance our focus between tackling the underlying biology of a condition versus addressing the very real, significant human impact of how it affects someone's appearance in life? That's probably relevant beyond just vitiligo.
That's a really thought-provoking question to leave things on. This has been incredibly thorough, and hopefully for you listening, a really high-yield deep dive into these vitiligo revision notes.
Yes, we hope breaking it down like this helps you structure your own learning from the material.
And remember, if you are looking for more resources to help with your revision efforts, do check out passthemsra.com and also freemsra.com.
Great resources there.
Thank you so much for joining us for this deep dive. We'll catch you on the next one.